Good morning. This is Steve Stites, Chief Medical Officer here at the University of Kansas Health System, broadcasting live from the Dolph Simons Family Studio. We're back with you again this morning. This is a 100-and-something episode of the COVID crisis. We wish there wasn't a 100-and-something episode. We wish there were no episodes. That would be the best. But as COVID goes on, so do we. And I think we are beginning, all of us, to develop what I'm going to call cows. You can ask yourself, cows? People don't have cows. Actually, we do. It's COVID weariness syndrome. Yeah. I believe we all have cows.
Yeah, absolutely.
And Dana, what are the numbers like today, and should we have cows?
We should, just because we still have COVID patients in the hospital and still get very sick, but overall the numbers are continuing to look a lot better, which is a very good thing. So 25 patients in the hospital today, 10 of those in the ICU though, so almost half, and then 6 of those on the ventilator. So
all right, and we still have about the other patients who are here with us that are after their 10 days of being infectious, so we don't count them acutely. They are in our chronic count. And
they are.
Are those still 20 or 25?
And that's
there?
25, 26. Yep.
Okay.
Yep.
All right, so still quite a few. Still
and because we've
patients.
had discharges, but unfortunately, as Dr. Wild talked about yesterday,
we're getting a lot of admissions.
We're continuing to get admissions.
Yeah, we are.
Even people who don't know they're ill, since we are screening all of our preoperative patients and all of our admissions to the hospital, we are finding some of those as well that are positive.
All right, so my family didn't think I would really say cows on the air, neither did the CF team. I warned them it was coming today. What do you think of COVID weariness?
I like it. I think
pretty good.
I think it should be patented.
I think it should be patented. I think we should put a little cow right here on the desk.
It's a true entity. I mean, everybody has it.
We all have
for
COVID weariness.
Various reasons.
And different degrees at any time.
Degrees.
All right.
Absolutely.
Chris Wilson is here. Chris is the VP of System Integration and Innovation. That's a lot of I's, but he also has cows. He's here at the University, in his job here at the University of Kansas Health System. Chris has done a great job helping us work with the University of Kansas at Lawrence, trying to put together our entire testing program there, working so hard to make sure we had testing available, helping coordinate what the campus return to school policy is going to be. So we're going to talk about how your work has been, and especially the work you're doing with Clinical Reference Laboratory. And their CEO, Robert Thompson, is with us today. We're just going to say CRL for short because it's quicker. It's kind of like saying cows instead of COVID weariness syndrome. We're going to say CRL instead of Clinical Reference Laboratory. They've been a great partner to the health system in trying to work through the testing that we're doing in Lawrence and elsewhere, and especially about saliva testing. So Chris, talk to us a little bit about your work and what's going on there.
Well, we've been partnering with the University of Kansas and Lawrence for a variety of infection prevention and pandemic preparedness and readiness around return to campus. And probably the most significant effort that we've undertaken is testing. So we're doing a variety of different types of testing work with the campus. And the biggest and sort of most timely topic is the mass testing and the entry screening testing that we're doing from a surveillance perspective. So this is for the asymptomatic individuals. These aren't the people that are already sick. These are the individuals that are coming back to campus, coming back to the Lawrence community. So students, faculty, and staff that are returning to campus starting later this month, with the idea that all of those individuals will receive a COVID test prior to returning to campus on September 7th, with some minor exceptions for those that maybe have tested positive in the past over the summer. But the goal is for us to be able to determine what the positivity looks like for that population as they re-enter campus, be able to identify pockets of potential positive individuals, intervene and prevent the further spread, and also establish a baseline for what the school year could look like, and then do regular surveillance testing for those individuals throughout the course of the year, with the overall goal being if we can identify positives from the beginning, remove them from the campus community as best we can, either keeping them at home, keeping them in isolation, removing them from the day-to-day activities of the campus so we can have as safe as reopening of campus as possible.
So yesterday, one of the big college headlines was at the University of North Carolina, where things have not gone especially well. What happened in North Carolina, and what are we doing to prevent it from happening here at University of Kansas?
Yeah, so unfortunately, the University of North Carolina went to all online classes yesterday after just about a week of being on campus. They had 3 outbreaks in on-campus housing, 1 in a fraternity, and positivity rates that were, I think, pretty alarming to the folks there. And so pretty rapidly they had to make a change and go from a hybrid model of being on and off campus to one that's online only. And so what we're doing, I think, is an approach that can help mitigate those situations. So
Because the Jayhawks are going to beat the Tar Heels.
that's right. Yeah,
That's the
yeah.
plan.
Well, that's the most important thing we could probably
I
talk
think
about
so.
today. So.
No question.
But you know, for on-campus housing, for instance, what the approach the housing director Sarah Waters did was great, I thought. So they do a stage move-in. So vast majority of the folks that are coming back to campus are coming, moving their their stuff in, their books and their clothes and their materials in, and then taking a test and then leaving.
Like a written test?
No.
It is college.
What we're doing is saliva testing.
Okay.
And so they're taking a self-administered saliva test that we partnered with CRL to perform. So when we get those positives, they're not on campus. So they're back home. That allows us to maintain isolation capacity on campus and also allows us to help monitor and reduce the potential for positive students interacting with others really before they have symptoms. So again, that asymptomatic, pre-symptomatic population.
That's a big deal. We thought it was mass migration coming to Lawrence. I think that kind of made us all shiver in our boots just a bit, and we had to come up with some strategy. Hopefully this is going to work. What do you think is the most important variable going to be, though? What will really determine our success or failure?
I think testing is probably the biggest thing that we can do right now. But very quickly, I think we're going to shift from continuing surveillance testing over to individual behavior and just how well
I think
the
it's
students
all
on
about
campus can get on board, basically with masking, with distancing, with demonstrating, modeling good behavior that we need to have during a pandemic. So that we don't end up like a situation that North Carolina has. And I was listening to a radio story this morning about campuses across the country, and they're interviewing students, and the students want to be back on campus. They really miss their campus life. And I remember at that time in my life,
Well, they don't,
it's a
they
pretty
don't
fun
miss
time.
mom and dad, they miss the
Right.
campus. That sounds familiar to me.
Right. But it's going to be different. So
Yeah.
they're going to have to adapt. Students have to adapt. Faculty, staff have to adapt. And so I think for the next couple of weeks, we're going to see a lot of that change management, frankly, of how they're going to have to re-enter the campus world.
All right, so Jayhawks beat Tar Heels. Do not get cows so bad you forget that you still have to follow the critical rules of infection control, because that's what's going to beat down the Tar Heels. So let's go Jayhawks. Robert Thompson, CEO of Clinical Reference Lab. A, I hope you're not a Tar Heel. And B, talk to us a little bit about the things you're doing at CRL to help keep our community safe and the campus safe. Let's talk saliva testing.
Right, when the crisis hit, we looked around and said, what can we do to help here? And we have a lot of experience with saliva as a testing matrix. So we decided fairly early on that we would focus on a self-collected saliva test, which in our study showed itself to be 100% as accurate as those big, long nasal swabs that you kind of go up and tickle your brain. And so, we worked our way through the FDA process. Things went really well. The FDA gave us our approval about 2.5 weeks ago. And now our goal is to help Kansas get back to work and get back to school.
So how does the salival thing work? Because we probably ought to talk a little bit about what it means to do pooled testing, which I think has been really important on the Lawrence campus and really for large businesses and other large-scale testing.
Right, so saliva there's a lot of virus in saliva. It's sort of very similar in terms of a sample type to what you would get from those long nasal swabs. So what we're doing with it is the same kind of test. It's a PCR test that tests for live virus. But we're also using this technique that you mentioned called pooling, where we take 5 individual samples that we've collected from students or employees, and we test them together in the laboratory. And that allows us, it actually reduces the cost and allows us to test a lot more samples much more quickly so that we can achieve the turnaround time that we're getting, which is currently 24 to 48 hours. We're averaging 13 hours right now.
So I just remember growing up, my parents always said, don't spit, that's gross. And now we're saying spit, spit, spit. It's kind of a different message for our culture and our society a little bit.
It is. This is one of the first tests that we've actually had where spit is an accepted matrix. It's one of the unique things about coronavirus, that there's a decent amount of it in spit. We're also looking at a new test that combines coronavirus and the flu, and 2 types of flu actually, and we'll be testing to see whether or not that testing is feasible in saliva as well.
That would be pretty awesome because that would mean no swabs, and
Right.
I'll be a fan of that one.
Which is really kind of one of the major benefits of the salival testing method is with a nasopharyngeal swab, you need a trained clinician who is there in PPE that's performing the nasal swab test.
Yes.
With the self-administered salival test, we're able to test much more people, a lot larger groups in a quicker amount of time without a labor force that, by the way, is also trying to take care of patients that are sick in hospitals and clinics right now.
Yep.
Without the PPE burn that we would have had otherwise. So it's a really advantageous approach for doing this mass surveillance testing that we're doing on the campus in Lawrence.
I like that. I think that sounds great. So good luck on that, and good luck. So now, you didn't really tell me what college you went to. I got to be careful I don't insult them as well, Robert. What's your school?
I went to the University of Pennsylvania undergrad and Harvard graduate.
Okay, so I don't think I'll insult those right now. My wife went to Princeton. I was nowhere near that smart. And I suspect, though, that the Jayhawks would beat them anyway.
Oh,
Chill.
yes.
Yeah, well, in many things, maybe not everything. Media questions. Not getting any, Jill? I bet there's questions from our listening audience today.
Yeah, and we actually do have one from a reporter who texted me last night with 41 Action News. And there is an Olathe teacher who was written up in the Washington Post for creating a Google Doc that tracks outbreaks in schools. And the reporter wants to know what the doctors and Chris and Robert, what people think about that. Is that too scary? Should we be tracking? And you might want to talk about the accuracy.
Yeah, Hawkeye. So you know what? I read about that last night. Jill prepped us, of course, and
Yeah.
she'd sent that out, and I was taking a look at it. I don't think it's scary at all. I think it's an interesting idea because people are essentially treating this. It's like a Wikipedia for school cases, and it's self-reported, self-administered, and the only thing is, like, when we report our data to HHS, there are some specific criteria we have to use to be very accurate. We're held accountable for it. Different bad things happen if we don't tell the truth, and so. The only thing I would say is that what this teacher is doing is probably a terrific public service.
Yeah.
It may not have the same degree of accuracy as what we report to, but I think it's an interesting way of being able to look at how schools are doing from the vision and the lens of the people that are working at the school.
Yeah, absolutely. I agree. It isn't protected health information. It's all done by the public, and especially, like you said, the people who are working in the schools. I think it's probably a good maybe bellwether of everything that is going on, or wherever somebody is reporting from. It should not be a scary thing. It is just that we have talked about. We aren't doing any of this to induce fear, but more knowledge, to let you be more knowledgeable about everything that's going on. I think this is one more piece of that. And I think if it is done by the public and the teachers, can you validate the accuracy? That's the big question. But it really shouldn't be for fear, but more for knowledge to give you one more piece to deal with and make your decisions from.
If we're going to be relying on folks for individual responsibility, we want to give them as much information as they can to be informed about their actions. And I think that's a great example of how we can get people more information to help inform what they're going to do in their day-to-days and trying to get back to whatever our new normal is.
Yeah, I think it's awesome, and I think having somebody take the initiative to do that is a great thing. And because schools are clearly such a major risk for all of us, it interrupts our bubbles, it changes our world, and our kids go out there and they come back and they're in contact with other kids, and hopefully we're not going to be like North Carolina and watch it go bad in a week or two. Hopefully it'll last longer, and hopefully we can get through a semester. So I think it's all about the good planning that people do. And then, like we are doing at KU, I strongly believe that this entry testing is a key, because you can get people isolated right away who are positive, and then you don't have the initial carriers going into the campus. And that's what scares me right there. So.
Yeah. Well, we're testing, 25,000 individuals in a community of 80,000 people as they re-enter this world. So it's a large chunk of the population.
And that's the students, but you're also testing the staff, right?
Yeah, faculty and staff as well.
That's a big number, approximately a very big number. Yeah. Okay, Jill.
Another reporter question, this one just in from Channel 9. How soon could we see the saliva testing, and where? Doctor's offices? Pharmacy?
All right. Robert, where are we going to see this testing? I mean, we're seeing it in Lawrence. If you're a student right now, you're doing it. So where else are you going?
There's a lot of activity right now. We're even in just the Kansas area, we're talking to several K through 12 schools, several of which have already kicked off testing this week. They're taking it very seriously. and most of our clients that I'm seeing, they are doing that entry testing. If they don't, you're effectively allowing, in case of a university, 100 to 200 COVID positive people to migrate to your town. That's a significant problem. So I think they're all doing the right thing. We are looking at doctors' offices. There's several employers that are doing this as well. And we have, it's been a lot of interest. We signed a contract just this morning, actually, with LA United School District. So we're the largest school district in California. And they're going to be doing testing as well. We can't do all of their testing, but we're going to be doing a chunk of it for them. So you'll be seeing a lot of us in schools, K through 12 universities, employers, and just now beginning to trickle into especially some of the urgent care clinics.
How many can you do a day?
20,000, and we're ramping up to, we think we can get to 50,000 by the end of September.
Talk a little bit about the Yale spit test protocol that came out, and people talked a lot about that on the weekend, got a little FDA action. So how is your things, well, first of all, tell us about the Yale deal, and then tell us how it's different from what you all are doing.
So what Yale did
Go ahead.
What Yale did was it actually kind of, it just eliminated one of the steps in the PCR process. So you go through, when you bring a specimen in, you go through an extraction step where it's the RNA extraction. So you're extracting the RNA from the sample, and then you go through PCR, normal PCR testing. They've eliminated that test, that first step, which is the RNA extraction. And to some degree, that's valuable because there's been a shortage of RNA extraction kits on the marketplace. And so a lot of places could do more testing if they were not doing that RNA step. It's not really a big piece of the cost chain. I think that's been a little misrepresented in the news, saying it's a $10 test. Yeah, it's $10 of materials, but materials are not the majority of the expense. The equipment, the personnel is really where all the expense lies. So I'm happy because I think it's going to expand the capacity of the nation to do more testing. The trade-off scientifically, if you don't do the RNA extraction, you lose sensitivity. And its numbers are roughly 5% false negatives and 5% false positives.
Yeah, it's kind of I don't like that number, especially depending on what the background community prevalence is. So, so you guys aren't going to eliminate that step. You're going to keep doing it.
That's correct.
How far are we away from having somebody be able to run it at their home by themselves?
Well, our test can be home collected, but you cannot run the test at home. So our FDA approval included the idea that we could ship a kit off to somebody. We're doing this with Emporia State as an example before the students arrive, and they run the test on themselves at home, FedEx it back, and we can do it. In terms of an actual full test being done at home, there are 2 or 3 companies that are working on antigen tests that do that. Now, antigen tests are also not as accurate. They will not pick you up in the early stages of the infection. And so, it'll have its uses, I think, especially if it's done quite frequently. I think we're probably a month away.
Okay. Dana, what do you think?
Yeah, I think that's great. Anything we can do to get more access to tests for everybody, that is going to be one step closer to us getting the spread of this disease down and decreased. And if we can get it to all of the health systems and the individual clinics and even, the other private entities like CVS that already offer vaccines and things of that nature, if we can get more access to testing for everybody, that is going to be one more step prior to vaccines and really other optimal treatments that we can do to stop this
especially
disease.
with the good turnaround time. So.
Yeah, I think it's just incredible if you think about where we were 4 or 5 months ago from a testing standpoint, where we were kind of using, let's say, the more traditional model of nasal pharyngeal swabs and going to your clinic to get a test, to then the drive-through approach. Now we're talking about saliva, then we're talking about home collection, now we're talking about home actually tests and analysis. In a very short amount of time. CRL's FDA approval was 2.5 weeks ago. And we've started mass collection testing for the students in Lawrence within the last week. It's a very, very quick turnaround time, and the growth in the industry and the Yale study, it's pretty impressive.
Dr. Burks quoted that when she was here with us on Saturday, Robert Thompson was there, Dana and I were both there, but she said that the United States is doing 70% of the world's COVID testing. That seems like a high percentage. On the other hand, we have 25% of the cases and 5% of the world's population. So there are some things that are a little off balance here.
Yeah.
Jill, next question.
People are wanting some clarification between if the saliva test that CRL is using is the DART test from Harvard, is it their test, is it the same?
Okay, you want to clarify this up, Robert, for us?
No, it's our own test. It is not from anywhere else. We are using the probes and primers, which is the critical function here, are from a company called Co-Diagnostics in Utah. But we took that, put it together with a collection device from Canada and our own methodologies to come up with our own EUA.
And so when you say that, Harvard could be having their own technique and their own, but the reality is that the testing that you guys have done has been validated. Our labs validated it. We worked together very closely, I think, to help make sure we felt good about it, helped work on the EUA together. So I think we're all really comfortable with the work that you guys are doing. We feel like it's, like you say, it's may well be as good as a nasal swab, and that's a statement most people can't make.
Well, our data certainly backs that up.
Jill.
Okay, Kim wants to know if you would clarify. She says a lot of college students are getting tested, then going back to their place and living on campus or off-campus housing before they get the results. What do you mean that they're going home?
All right, Chris, let's clarify that a little bit.
Yeah, sure.
Part of our protocol.
For the on-campus housing population, there's a large portion, I think it's about 75% of the on-campus housing population that lives within the region. So those individuals are doing a staged move-in. So they will come, move their things into their place, into their dorm room, take a test, and then they leave. They go back to their home. And then by that point in time, they get their results. And if they get a positive, they will stay home. They won't come back to campus as a positive.
Yeah, they have to wait for 2 weeks or 10 days. How long do you make them wait?
Yeah, so the same process that they would use and that we would use advising a patient. So if they're positive and they're asymptomatic, you're going to have 10 days of isolation and 72 hours of being symptom free. If they develop symptoms or continue to have symptoms, it'll be until those symptoms resolve. So it'd be the same time frames that we would use with patients as we have for the last several months.
I'm sorry. What happens if one of the students lives further away, say 500 miles away? Do they have to go back home, or what's the accommodation there?
So the campus in Lawrence has invested in some isolation housing, some specific facilities to be able to house students.
Naismith dorm.
Yeah, so I think it's around 200 units total that they have that are available for isolation housing.
And to add that, we've worked closely with Lawrence Memorial Hospital as well as Watkins Health Center to try to make sure people are ready for more patients. And actually, we've done modeling with the county so that we can know that LMH is ready for any potential influx of students. And if they're not, we will be.
Yeah, LMH has been a great partner. So in fact, LMH has helped us manage the testing for the faculty and staff with the saliva surveillance testing. So Jared Abel's done a great job with that work. And we've partnered with analytics teams and population health teams in the county, a lot of physicians, yourself and Dr. Hawkinson, to project what we think the impact of the students moving back to campus will be. Results so far look like LMH would be able to handle any of the cases that arise and the hospitalizations that arise from that, the students and the campus reopening. So there's a lot of good work that's going into that. It will continue daily. We'll update that information regularly. We get more information every day, whether it's results from testing or pockets of individuals that have tested positive or not tested positive. We're seeing some pretty good results so far.
Yeah, that's great news. And so we're trying to make sure these students stay safe, keep the community safe by doing that.
And we do have all those partners meeting daily. I mean, you organize it every day, so we are meeting quite actively and frequently about all this.
Yeah, we have a meeting at 7:30 every morning that Dr. Hawkinson gets to attend prior to coming on this show with several physicians and leaders in the Lawrence campus, Lawrence Memorial, and the University of Kansas Health System that are reviewing data, that are talking about issues that may have come up in the last 24 hours. And then every week we get our pandemic medical advisory team together that Dr. Stites chairs to really look at what are some of the critical factors and key decisions that we need to make to help keep the campus and the community safe.
And you wonder why we may have cows. That's COVID weariness syndrome for those of you who didn't tune in at the beginning of the program. Jill, next question.
All right, so Craig has a multi-part question. He wants to know how long from a positive test result is someone likely to shed the virus? And then as he follows up, he gets down here and he wants to know, is there a T cell response test?
Oh, here you go, Dana. Somebody wants to dig into a little science, buddy. Let's do that.
That's good. Well, I do have to present a journal club to all the infectious disease faculty and staff today, so and the fellows.
Is that being zoomed live so people can hear what you're
It's
doing?
on Blackboard, so I think it's just internal, so
Okay.
anybody else on campus can look at it. But basically, one of the journal that I'm presenting answers one of those questions. So there are 2 or 3 or 4 good peer-reviewed articles that talk about how long are you infectious. The best evidence we have right now is about 8 to 9 days from your symptom onset. And this is based on symptoms. It is based on upper respiratory tract, PCR viral load, as well as the ability to obtain replication competent virus or culturable virus. And so what they found is that really after about 8, 9 days, they were unable to identify replication competent virus from the upper respiratory tract. So that is what we're thinking, and that is what the CDC guidelines are based on, those references. That is what the KDHE guidelines are based on, those references. Certainly we are always ready and willing to accept more information and data, but again, those are the best peer-reviewed articles. One of them I think is from Nature, one is from New England Journal of Medicine, so it's a wide variety of really respected journals. And to answer your question, it's about 8 to 9 days, and that's why we use the 10 days after symptom onset.
All right. So I think the T cell response, what are you
T-cell
thinking about
response.
that?
Yeah, so T cell response we know is extremely important in this and many other viral diseases. There have been studies out there showing maybe there's some cross-reactivity from other common coronaviruses that cause the common cold, and that just means that those T cells may respond to this new SARS-CoV-2 as well. I think that's pretty minimal, knowing that we have 80 to 90% of adults have had contact with those coronaviruses, and you obviously